one of my points in this next slide is that this uh, presentation will be recorded. We're asking that everyone stay on mute and go ahead and submit questions for our Q&A towards the end in the chat, and you can submit those as we are going along, so we have an opportunity to sort of read them and orient ourselves before answering you towards the end. The slide deck and webinar recording will also be available on our Reentry website. Next slide, please. So today we're reviewing a couple of the requirements outlined in or attestations outlined in the CBA, the capacity building application, which many of you have submitted. We're going to touch on the staffing and governance requirements, which is attestation number 2, as well as discuss a bit of the data exchange requirements and kind of outline some scenarios in which that might be relevant. And then we'll go ahead and have some time for Q&A at the end. Next slide, please. Okay, so if you are this is our, milestone deadlines. We are releasing the readiness assessment here fairly soon, and so we'll expect the deadline for that to be April 4th. We are on the very tail end of having it wrapped up and sent out to you all. And then just a reminder for those of you who are in cohort 2 that your capacity building application is due on April 1st. Next slide, please. This goes over both of the milestones, which you may be familiar with by now. Milestone 3 is becoming more relevant as we get closer and closer to that deadline. And as you may remember, facilities need to pass the readiness assessment to go live in July. Next slide, please. So these are the different attestations that we have, or sections we've gone over in the Learning Series webinar thus far. And the billing and claiming one, I think we may have renamed that for the future, but right above that, we're at no cost to individual staffing governance and data exchange requirements. And that's going to be today's webinar, where we'll go over all of these sections. Next slide, please. And these are the specific sections that we will be referencing today to sort of ground us in the information that we're sharing and weave in why today's information is going to be relevant to you filling out your capacity building application as well as your readiness assessment. And I will pass it over to Emma. Thank you.
Thank you, Michaela. Next slide, please. So as Michaela was saying, we're just wrapping up all the loose ends that we have not covered thus far in other webinars. So we're going all over that capacity building application to just check off the rest of the attestations that we haven't had a conversation about yet. So next slide, please. I got the easier ones today. So I'm going to be talking about section 1 of the capacity building application and section 2 of the capacity building application. So section 1 is the first section that you see when you open the capacity building application. This is the attestation about no cost to individuals. So because we're a Medicaid program, under the reentry demonstration, facilities cannot charge individuals or healthcare providers for any reentry services or any activities associated with those services. That's just one of the pieces of being in Medicaid. This could mean that there will be some changes for your facility. And so in particular, what I'd like to highlight are communications in any form. So emails, phone calls, anything health related that's related to Medicaid services that you're going to be providing. There cannot be a cost to individuals associated with those services. Any provision of medical care, prescription drugs, you can't send a bill, you can't balance bill anybody as a result of providing those services. Even things like asking for help with filling out a Medicaid application, can't have a cost associated with that for individuals and verifying eligibility. I think that's fairly straightforward. So we actually haven't gotten a lot of questions about this attestation, but I think we were expecting to, especially the part about communication in any form where there might be some sort of facility requirement today around costs of an email, of a phone call, of receiving mail. So we just want to reiterate, please, please feel free to reach out to us if you currently charge for any sorts of communication, any of these additional activities, and you want to have a conversation about a glide path to how you would no longer pay and participate in this program. HCA team, I'm getting a message that I think there might be people in a Teams meeting again. So could somebody please run and check on that? Thank you. And so just also want to reiterate, thank you, Michaela, that no charge for any providers that might be providing services. Providers can be paid to provide services under the Reentry Demonstration Initiative, but there wouldn't be a charge for managed care organization, accountable communities of health, other types of providers to share information with clients about health services that they're receiving. Any Well, we can take questions at the end, so thank you. And next slide, please. All right, and so this is section 2 in the capacity building application on our staffing and governance structure. And we have gotten a number of questions about this one, so I'll talk about some of the questions we've received. So this is the attestation that says participating carceral facilities must establish a staffing and governance structure to support planning and decision-making for implementation of the Reentry Initiative. We've definitely gotten a lot of questions along the lines of what does this mean? Like, help us understand this. And so I think it's a pretty light touch requirement. We just want to make sure that you have all of the staff in place to be able to provide mandatory health services following our program requirements. And then that governance requirement says that you just need to have some sort of decision-making structure for your facility. So just putting those two pieces together, do you have all the right staff that you need to provide healthcare services and support this project and all the non-healthcare delivery pieces? And then on the governance side, just decision making. So if there's any questions about the requirements in this section, please feel free to reach out to us and we're happy to talk more. But otherwise, I think if your instinct is, yep, we already have this, we are not concerned about these pieces, you're probably on the right track there. All right. I think I'm turning it over to somebody else. So thank you. And next slide, please.
Tara, I will be talking about this next section to review process requirements around eligibility benefit. Next slide, please. Under these key processes, we'll verify Apple Health Medicaid eligibility and enrollment status, submit Apple Health Medicaid applications, provide booking and release information, share carceral health history and RTCM providers or with RTCM providers, share reentry care plans with post-release providers, submit claims and reentry initiative benefit services. Next slide, please. In this slide, we'll verify Apple Health Medicaid eligibility and enrollment status. So there's two pathways. So facilities have two paths to access provider one and verify an individual's Apple Health eligibility and managed care enrollment status or fee for service status. We have provider one, where Apple Health billers or providers have direct access into provider one by using the provider one provider portal. The second pathway is One Health Port, which is a secure portal where Medicaid billers and providers can access provider one. Next slide, please. This slide will review how to submit Apple Health Medicaid applications. So for the purposes of eligibility and processing applications, Apple Health is divided into two application pathways, and eligibility criteria and requirements can vary for each program. Facilities will need to determine which Apple Health application pathway should be used based on this eligibility criteria. First one is the modified adjusted gross income, or we refer to as MAGI-based program. For MAGI-based program, online through Washington Health Plan Finder, you can apply if the client is an adult age 19 to 64, or applying for children under 18, parent or a caretaker applying on behalf of a child, pregnant individuals, or individuals applying for someone who is pregnant. That application pathway online, mobile phone, or paper. Sorry, I can't read that. So those are just some of the options that facilities can use to support and facilitate individuals applying for that Apple Health Magi-based programs. The second pathway is Apple Health Classic. So for Apple Health Classic coverage, that's online through Washington Connections. And this is if, so the eligible populations are if an adult is age 65 or older, eligible for Medicare, individuals who are blind or disabled, and individuals who need long-term services and support. And for those applications, facilities can use online, paper, or by phone. Next slide, please. I think this is where I'm past Arthur for the benefits section.
Can I interject just real quickly? I know that Tara, you may have to hop off a little bit early, so I just wanted to give an opportunity for you to answer a question that came up in the chat, which is how is income calculated when jail residents are incarcerated? They cannot work while incarcerated.
Yeah, so if they're already eligible, right, so they already have Medicaid eligibility, then they would need to update that income, right? And if they're new, then they would apply for Medicaid with the income that they're making at the moment. Does that answer the question, right? So if the income is there, you report it. If the income is not there, you wouldn't report income.
I'm hearing that if the individual is already enrolled in Medicaid or Apple Health, that they will continue to be eligible and that
Sure. Yeah. Anytime there's an income change, you would calculate, right? To be calculated, you would report it. So, because not everything is Medicaid. So, if somebody did have private insurance, right, and now they want to apply for Medicaid while they are incarcerated so they can be eligible for the pre-release services, you would put zero income if they have no income while they're incarcerated.
Thank you, Tara, and I'll go ahead and hand it back to Arthur. Thank you so much.
Hi, everyone. I'm Arthur Andrews, occupational nurse consultant here at the Healthcare Authority. I'm sure many of you have seen me in previous benefits webinars here. My focus is reentry services. So I'm just going to talk a little bit about the reentry targeted case management, informed consent, and we're going to talk about something else really briefly too. It's escaping my brain here. So basically on this slide, what we're, I'm not going to read it word for word, but what we're talking about here is that, carceral facilities are going to need to share health history with the reentry targeted case manager. That could be much easier if you're employing your own internal targeted case manager, right? But if you're utilizing an external resource like, the TPA is going to support or the managed care organization is going to support that, you're going to need to be able to share that health history with the targeted case managers so that they can connect them to services, do their assessments, and make sure that continuity of care is happening, especially in that period between incarceration and release. And so targeted case management is available 90 days prior to release. For those short stays, we've talked about this before, that you can only use the best information that you have in the moment. So really for those short stays, that 90 days would be at the time of booking, right? And in previous webinars, we've released kind of a time frame of when those expectations are kind of in place and what we expect those services to be started. And then just calling out here that that sharing of information can happen, electronically. It can be secure transmission. It can be paper-based. It could be over the phone and giving that handoff, those types of things. So, and then really just calling out that I think this has come up on some previous slides here, that you may need to get the individual's consent to share information, right? Especially when you're talking about sharing information with like an external provider who's going to be doing that targeted case management for you. If the MCO is going to be providing that targeted case manager, they may need you may need a release of information from the person in order to share information with that external provider. And calling out again that individuals have the right to participate in the amount of healthcare that they would like to participate in. So while they could tell you that they want to participate in targeted case management while you're in their facility, they may not want to share information externally, and so they have that right to refuse to sign the informed consent and stop the targeted case management at that point. So just calling that out, we're not forcing healthcare on anybody. We're not compelling that on anybody. There are, ways to do that through the legal system, but they are few and far between, and they are the extenuating circumstances. Next slide. And talking about individual, securing that consent. If you're going to be sharing private information, healthcare information with outside entities, you're going to need to get that individual consent from the person to be able to do that. I would like to call out that there are some special circumstances, especially in the world of substance use and mental health, where you're going to need to have consent even for continuity of care issues. So there are extra protections in place in those realms. So just recognizing that, as a qualified healthcare entity providing healthcare services, you're going to need to comply with, HIPAA and the rules that come with that. So there is an example of on our website, on the reentry website, of an informed consent that you can use, but you may have existing processes in place that you're using now. Your healthcare providers are probably already familiar with informed consent and when it needs to be done. So you can leverage your existing resources, or you can use the resource that we have online for you if you'd like, and then just recognizing that people do have the right to privacy and to participate in the amount of healthcare that they want to participate in. There's a bullet here that says you need to track when individuals do or do not provide consent. Really, that's about tracking, making sure that the informed consent is in place for you to be able to share information with the outside providers that you need to share information with. So this is not a outside of healthcare norms. This is a healthcare norm, very much so. And so just making sure that we're calling out that, consent will be needed. So, and then sharing that carceral health history with those registered targeted case managers, right? So you went backwards. Forward two. No, that's backwards. Forward one more. And then with the targeted case management, this is really related to the targeted case manager, right? Because targeted case managers are going to do a comprehensive assessment. They're going to develop a care plan based upon that comprehensive assessment, as we've talked about before. This is normal within the realm of registered nurses, social workers. We all do care plans. Care plans should be person-centered. They should be actionable, and they should be goal-oriented, right? And they should be individualized for the individual. And so just really recognizing that as part of that warm handoff process, the sharing of that care plan should also be shared during that process as well, right? This goes along with the warm handoff to ensure that continuity of care. It lets that next case manager know that what has been done, what is pending, what still needs to be done, and really kind of helps drive the work for the individual moving forward. This should be done 14 days prior to release. Best practice, Otherwise, no later than 7 calendar days after release. We know that those unexpected releases happening. So just, recognizing that that's kind of the time frame that's called out there, but I'm really just doing this as soon as possible, not delaying after release, and really doing it before release if you can is best practice, because it helps set up the next targeted case manager for success with that individual, right? They can plan for that release, and kind of plan when to contact them and follow up with them. So again, this can happen a variety of different ways. This can happen through electronics, email. It can happen paper-based transmission. However your facility decides that they're going to set this process up, with whoever you're working with, and really calling out too that this is only going to change, and you're only going to need to share and do that warm handoff if that targeted case manager is changing between pre and post release, right? So if the MCO is providing that care pre-release, they're going to follow that individual post-release. This would not need to happen. They would already have the information. They would have already developed the care plan and the assessment, and they'd already have that information. So that warm handoff would not need to occur in that time frame. So, and then again, calling out individual consent, right? If you're going to disclose and you're going to share information with outside entities, that individual consent needs to be acquired in that case. So, and that's it on that one. Next slide. And I think I'm passing off to you, Emma.
Thank you, Arthur. So I'm now going to be talking about the CBA Section 4, which is our provider enrollment and billing section. And then question 5, which is carceral facilities providers can bill HCA and MCOs for reentry services. Just to be super clear, all of the other slides that you were just looking at were specific attestations in our capacity building application. We're going to take this deck back and make a couple of edits just to make sure that that's super clear to everybody, and then we'll share this deck. So thank you for your patience with this, but I will walk through this last one. And so this last attestation, it's about being able to bill. And so we just wanted to highlight that there are 2 ways that facilities or their contracted providers can bill for reentry demonstration services. We've definitely talked a bit about this in the past. We absolutely will talk more about it in the future. So that first way is that they can bill HCA and our MCOs directly. And this is really recommended for probably our contracted providers who already provide Medicaid services in community today, and a facility is meeting all of the services requirements of the reentry demonstration by contracting with a provider group that, again, already bills Medicaid. And so what we would expect is that provider group that already bills Medicaid would just continue to follow their existing billing pathways by working with MCOs or by submitting claims directly to MCOs and then directly to healthcare authority. Our second pathway is it's really for these facility providers that are new to billing Medicaid and working with a facility directly. So are employed by a facility, maybe a third party group that is not directly employed, but is contracted with the facility and is not billing Medicaid directly in another way. And so in the second pathway, facilities can submit their claims to our third-party entity, what we've been calling the TPA, which will be a claims clearinghouse, which will then submit claims on your behalf to healthcare authority or to MCOs as appropriate, and then you would receive payment for services. And so we're currently in the process of procuring that third-party administrator, and more information to come on that second billing pathway in the future. So I think that's it for me. We really sped through this today. We're going to do some Q&A now, and I know there's a number of questions in chat.
Not too many questions in chat. While we have Tara on here, maybe she can give a little bit more of a thorough answer vocally. But we have a question: how would we address youth who are not connected with their parents/guardians? Can they still sign up for Apple Health if they're under the age of 18?
Yeah, I don't know if you're able to see my response, but I did. I just said that, right? the process would need a little support. And I think that some of those processes for juvenile facilities will outreach and build those processes. But you can even, under 18, and if they don't have their parental support to apply through a household, there are special processes, but it would definitely need HCA support.
Sarah, can I ask a follow-up question about that? If
Mm.
this is a scenario that happens for a facility, how should they get into contact with healthcare authority for more information?
So I think that's something that needs to be added to some of the documentation that's already out there. But it would need to come to the ethics team. So Emma, I would reach back to you because I don't, right? I mean,
So we're gonna take that question back then. Thank you so much, both of you guys.
mhm.
Thank you both. We had a little back and forth about where the example consent form lives, and it's on our reentry website under general materials, uh, titled Authorization and Information Sharing Consent Form for Reentry Case Management, which has been posted in the chat. We have a question. Can HCA confirm that the last slide is not applicable for pharmacy point of sale claims? Pharmacy point of sale claims would not be submitted to the TPA.
Arthur, could you assist with this one, please? Thank you.
Emma, did you leave that to me? I'm sorry, I didn't
No,
barely hear.
sorry.
Oh, okay, I
Arthur,
could barely hear.
no, I'm like talking to myself. Arthur, would you be able to answer this one about pharmacy points of sale? Or we can take it back.
The requirements for the pharmacy point of sale, that's correct, that it would need to be, a pharmacy's requirement is that it has to go through the point of sale system directly. So that is a requirement for pharmacy.
Great. Thank you.
That's the end of our in-chat questions. Do folks have additional questions that are either related to the material that we've posted today, or I know we released a section of the P&O guide that we sent out to you all, as well as some additional budget guidance for submitting your CBA. Do folks have questions about any of that stuff? This can be an open forum. There was an early item in the slides about billing and release information. I didn't see that covered in the slide details. I'm not sure exactly which section uh, this individual is referring to. Emma, do you have a sense?
I don't, but I am realizing we are getting a bunch of MCO questions. Can we hold those questions, please, and bring them to the internal MCO meeting? Thank you.
On the slide, it mentions that providers can send in a paper form to be paid. Is this standard CMS 1500 or technical language that I'm not used to? Or is there a special format like with CBHS that they have to use?
I don't know if we actually have a billing expert on the call today. Arthur, are you able to answer this? Otherwise, we can take that back as well.
I am not able to get into the details about billing. No.
Great, we'll take that back. Thank you for that question. Very detailed. Okay, and I think we still have some confusion about the pharmacy point of sale. Arthur, if you can see in the chat, it says, can you please clarify the point of sale for pharmacy services? For instance, if we have a jail that has a pharmacy but no POS, are we not able to bill for meds?
Yeah, my understanding, Mackenzie, is that the pharmacy POS system is a requirement to bill for meds. So those meds have to be billed directly.
I'm curious, have folks had an opportunity to review the P&O guide we released? Um, and if you haven't, or if you haven't seen it, please put in the chat and we'll go ahead and link to it.
So you know, next slide, please. Thank you. Thanks, everybody. Since we actually have some time today, let's just go through a little bit more. So we did, I think, as a reminder, we released a section of the Policy and Operations Guide, which is very exciting. We have a few more sections coming out in March. And then next slide, please. Just a reminder that we have a readiness assessment webinar coming up soon. So this time next week, or 10 a.m. next week, we're going to do an intro and walkthrough of the readiness assessment. And then really we're done with our learning webinar series. So just a reminder that all of our recordings are on our website. Please feel free to ask more questions. And over this month, you'll see more sections of the Policy and Operations Guide rollout. And then we're going to do another Q&A session on March 19th. So please come bring your questions. We're happy to answer them. Please feel free to send them to us in advance. And we'll just devote some time to answering some more questions. We'll get all of our subject matter experts here. And yeah, so looking forward to it. So more information coming really soon on capacity building funding for folks that have not submitted, or sorry, for folks that have submitted their capacity building application. And, for all of the folks in cohort 1 that have not submitted their capacity building application yet, we would encourage you to maybe think about trying to submit along the lines of with that cohort 2. So our deadline for cohort 2 was April 1st. And I think now's a good time to maybe take the next month and go and take another look at that and fill that out and try to get that back to us by April 1st. I think just kind of trying to get everybody back on track with the cohort would be really helpful. And then we'll have some future conversations about start dates. But so there is one group of folks that have completed their capacity building applications that will be in touch soon about payment. And then there is a second group that we're still waiting for capacity building applications from. Thanks, everybody.
And then actually, this is something Michael and I have been discussing lately. Michael, do you want to take this? Is there any information regarding Epic?
About the HCMAX, you mean our program here within the state of Washington? Sure. Actually, if we could we go back to the billing slide while we talk about that? That'd be helpful. So what Michaela was prompting me about is that we have a program that Healthcare Authority has been developing about providing electronic health record system to organizations that typically have a difficult time purchasing and implementing an EHR. And that program is scheduled right now to be implemented sometime around mid-2027. So with a date that's parked that far out, please take that with a grain of salt. It's just the scheduled date when we would hope to put something like that into place. And we bring it up now because as we've been working through the Reentry Initiative, we've mentioned HCMAX, and Michaela, maybe we can put what HCMAX stands for in the chat. And we knew that some facilities wanted to be a participant in that program because it would give you access to an electronic health record system. So what we just want to begin communicating is that with a date so far out in the mid 2027, it's really not likely that any kind of access to an electronic health record system through the HCMAX program will be available as we're implementing through the reentry. So, Michaela, let me turn it back to you. Is there any other detail you wanted to make sure we talked about this afternoon?
Yeah, so on that specific point, I will be sending out a communication to all facilities, sort of summarizing what Michael just said, that we are unlikely to have HC Max available for those of you participating in cohorts 1 through 3. Um, However, we have a wonderful subject matter expert who has volunteered her time to help any facility who needs to invest in an EHR navigate what that might look like, as well as, the options that are available to them. And so reaching out to the inbox, I can direct you to her,
Sure.
who is, she's already agreed and she's been our head person of the HC Max project, uh, agreed to work with facilities, one-on-one to sort of figure out what's going to work best for them.
And just to wrap that, thank you, Michaela. Just to wrap that up, of course, electronic health record system that we were focusing on through HC Max, would have provided Medicaid billing module, which is required for the reentry initiative. And it also would have provided electronic health record system, not required to participate in the reentry initiative, but obviously very helpful if facility participating in the initiative. So thanks so much, Michaela. I wonder if I could just pivot real quick here, Michaela, Emma, just to talk about billing for a minute, because Chris, you're asking questions about when is the billing training. You're also asking questions about paper documents. I just want to clarify that what we're talking about in this slide here, Chris, is that the paper documents could be received by the TPA. And so you're right, we need to get back to you to clarify better which documents the TPA would accept. We'll have to work with our apparent successful bidder on that particular question as we're putting together the contract. But the idea being that the TPA would then turn that paper document into a claim that could be submitted to the healthcare authorities. So again, just wanted to take a minute to clarify that when we're talking about a paper document, Chris, we're talking about what we would like the TPA to be able to receive, then turn that into an electronic document that the healthcare authority would then do the claim processing on. So we can tell you that for now, and then you're right, we need to get back to you on just which paper forms.
Thank you so much, Michael, for all of that. Speaking of billing, Emma, I see you answered a question in the chat about when billing training might or might not occur.
So I think we should wrap this into the presentation we're going to do on the third party administrator and working with them, which is we're going to have a presentation on that, but we're probably a couple of months away from that. And so we haven't scheduled anything on our calendar formally yet. I definitely am taking back, I think we're hearing we need to provide more information on the pharmacy point of sale system. So we're going to take that back as well and think about what we could do there.
Yeah, Chris, I see your comment. Emma's talking about we need to get into that all in one discussion. Thank you, though.
I know that cohort 2 facilities also have their capacity building application deadline coming up. Does anyone want to take an opportunity to ask questions about that? We do still have some time. All right, if not, we may go ahead and give you all some time back. I know how valuable that is. Really appreciate you taking the time to join us today. We'll go ahead and wrap up.
Lindsay, Michaela, Emma, Arthur, Tara, everybody, thank you so much.
Thank you.
Thank you.